Okay, so thank you to everyone that's joined so promptly. I'm Lily, I'm the Neuro Oncology clinical research practitioner that works alongside Dr. Matt Williams, and we both host the Horizons in Neuro Oncology. And I know a couple of you have asked me about the recording from last month. Unfortunately, due to it having patient data on it, we have to edit it, and so it will be made available um, in the next week or so. So bear with me, and I'm sorry about that. I hope you're all okay, that this session will be recorded. If you've got any issues, please do let me know, and I'll do my best to accommodate. And the slides and the presentation will be made available also after this on our YouTube channel. So today we're very lucky to have Dr. Lorimer, sorry, pardon my pronunciation, who is going to talk, consultant oncologist working at Brighton, and she completed her SBR training between Brighton and the Royal Marsden and is currently an acting consultant in Neuro Oncology. Her research work was funded by a local charity, the Sussex Cancer Fund, with some extra input from Brain Trust, and today she'll be talking to us about the management of older and frailer patients with glioblastoma. As always, if you've got any questions, please place them in the chat. We will have an opportunity to ask questions at the end of the presentation, and I will also take questions from the audience. I have put a qualtrics survey questionnaire into the chat, so as always, please also provide your evaluation, as that feedback is really important to us to help us improve these presentations. And I won't talk any further, and I'll pass over to Dr. Lorimer.
Thanks very much, Lily. And I want to say thanks also to Matt for inviting me to speak as part of this seminar. I'm just going to share my screen so that you can all see my slides. If you could just, if I put them into presentation mode, and hopefully you should be able to see them okay. So my name, as Lily said, my name is Dr. Cressida Lorimer, and I'm a clinical oncologist. I've just started a consultant job down in Brighton. And what I wanted to talk to you about today was about the management of high-grade gliomas, mainly focusing on glioblastomas in older or frailer patients. And this is some work that I have done over the years. I took some time out of my training to do a research degree, looking particularly at the management of older and frailer patients with glioblastoma. I know it's quite a broad audience, and so I've kept the talk relatively broad, but I'm very happy to take questions at the end if you wanted more details about any particular part of it. So what I was going to do today is just do a bit of an overview about the instance of glioblastoma and talk through treatment options and how they can change slightly depending on the age or the fitness of the patient. And more importantly, about how we as doctors and as patients assess that fitness so that the right patients are getting the right treatment, and research that's been done within this area, both by myself and others, and then looking at future directions of where this work might go in the years to come. I have no disclosures, and most of my work has been funded very generously by the Sussex Cancer Fund, which is a local cancer charity based in Brighton, serving all of Sussex. So just to start with, and apologies if the audience know this already, but just as a kind of overview of the disease that we're talking about. So gliomas are types of tumours that arise from the glial cells that make up the supporting structure to the brain. And they are what we call primary brain tumours, which means they come from the brain tissue themselves rather than having spread from elsewhere within the body. And they can be graded from 1 to 4. Historically, this was how they would, this is all how they were graded. So a histopathologist would look down a microscope, have a look at the cells and see how abnormal they were, and then grade them from 1 to 4, with 1 and 2 being what we call low-grade tumours, and 3 and 4 higher-grade tumours. And then over the years, as our diagnostic ability has got better and new ways of classifying tumours and doing deeper understanding of the molecular markers of this tumour has developed, the World Health Organization reclassified how we classify these tumours looking more particularly at particular molecular markers on these tumours, the most important of which in terms of grading are the IDH status and the 1p19q status. And those are helpful in terms of guiding prognosis and in terms of guiding how we can relatively expect these tumours to act. There are other molecular markers, so you may have come across something called MGMT. So we talk about methylation of the promoter region of the MGMT gene. And this is a marker that can be helped to use response to treatment. So patients who have methylation of the promoter region of the MGMT on their tumour, which is about 50% of patients have this, tend to respond slightly better to chemotherapy. And so that can be used as a marker when we're thinking about treatment to help guide. Glioblastomas used to be that all grade 4 astrocytomas were called glioblastomas, but actually with the reclassification in 2021, glioblastomas are now technically those tumours that are IDH wild type grade 4 astrocytomas, and they represent the more aggressive end of the spectrum in terms of these glial tumours. And that's the tumour that I'm going to focus on most today. So glioblastomas are the commonest of these primary malignant brain tumours. So of the tumours that arise within the brain, about 30% of them are glioblastomas. So and the UK incidence is around 2,000 to 2,500 new cases per year. So in terms of cancers within the UK, glioblastomas are rare, despite them being the commonest primary malignant brain tumour. And the average age of diagnosis within the UK is about 64, but the incidence rates are increasing as people get older. And partly this is probably to do with the fact that we're better at picking up these tumours due to better imaging than we used to have before, but also that patients are living longer and people in general are living longer. So if we look at statistics from the UN, we can see that the world population is gradually getting older. There's been phrases such as a silver tsunami, to show that actually as people's life expectancy is improving, which is excellent, it also means that the number of cancer diagnoses are improving because cancer tends to be a disease of the older person. So around 2/3 of all cancers occur in people over the age of 65. And you can see from this graph from the Cancer Research UK website that it shows this isn't looking at glioblastomas, this is looking at all cancers. But you can see that as you get older, your chance of getting cancer increases. And so looking particularly at glioblastomas within the older person, and there isn't a kind of set age cutoff for this, it's a spectrum of different people age very differently. But unfortunately, we see that even though glioblastomas don't have a great prognosis in general, as you get older, that prognosis can drop. So this graph on the right-hand side, which is actually from some work that I think Matt might have been involved in, looks at the survival depending on age category. And as you can see in those patients aged over 70, their survival is significantly lower than the patients younger. And there are many different reasons for this. Historically, it was thought that older patients had more aggressive tumour biology, but actually that's changed slightly since the 2021 WHO reclassification. And actually, there's quite a lot of interest in what we call the peritumoral area. So within the brain, where you have the tumour itself, the normal brain that surrounds that tumour, there's been some work looking at how that normal brain reacts to the presence of the tumour in terms of its immune system. And there seems to be an age-related difference in terms of that response. But also the fact that a brain tumour doesn't occur in isolation, it occurs within a person. And that person, as they get older, are more likely to have other medical comorbidities. So things like diabetes, high blood pressure, potentially other cancers. And that can mean that their tolerance to treatment or their frailty can be different depending on their risk of comorbidities and what we can sometimes call their comorbidity burden. Historically, there's also been the potential for undertreatment. So I don't think this is true so much anymore, but I think historically people used age as a chronological number. So there would be more of a cutoff of saying this patient is a certain age and therefore maybe not suitable for treatment, rather than thinking of age more as a biological process rather than just a numerical process. And there is also a lack of clinical trials within the older cohort. So looking across oncology in general, this is a graph from done quite a few years ago now, but published in the New England Journal of Medicine, which looked in America at the proportion of elderly patients with cancer compared to the proportion of elderly patients who were in clinical trials. And historically, there's been a poor representation of older patients within clinical trials. So ironically, given that cancer is a disease of the older person, the evidence base by which we treat people is often done in patients who are younger. And then that evidence is then extrapolated into older patients. So within glioblastoma, the treatment options, I'll just run through now. Like the first line treatment tends to be surgery. And there has been questions over the years about the degree of surgery. So how much surgery is correct. It's always been felt that actually the more of the tumour bulk that you can remove, the better people do. But it's about the balance of making sure that the side effects from that treatment or the potential functional deficit from that surgery isn't too great. There was a large meta-analysis, so a kind of summary of all trials that was done a few years ago that looked at people who'd had part of the tumour removed compared to as much of the tumour as possible removed. And that suggested that patients who had more tumour removed did better. And that again carried on over into the older age group as well. But these were, whenever you look at retrospective studies, they are subject to bias. So often it would be patients whose tumour was more accessible that inevitably had more of it removed, or people that were maybe fitter preoperatively who could undergo a more extensive operation. And so although the kind of nuance of it is probably that more tumour that's removed, the better, even in older patients. That's something that has to still be balanced on a patient-to-patient basis. And after surgery, so even when patients have had a really excellent resection, and we work with incredible neurosurgical colleagues who can do fantastic things, we know that unfortunately there are abnormal glial cells left behind, and those glial cells will regrow at some point. And so therefore, we look at giving adjuvant treatment. And from an oncological point of view, this is normally what we call the STUP regime. And the reason it's called that is that it's based on a clinical trial that was published number of years ago by a Professor Roger Stupp, who looked at giving radiotherapy after patients had had their glioblastoma surgery. And it was known for quite a while that radiotherapy improved survival. But the feeling was if you could give something that would make radiotherapy work a bit better, whether that would be what that benefit could be. And so he did a trial looking at giving 6 weeks of radiotherapy with additional chemotherapy at the same time, and then the chemotherapy alone after the radiotherapy had finished. And that trial was only done, unfortunately, in patients between 18 and 70. And did show improvement with the addition of the temozolomide chemotherapy, especially in those patients who had MGMT promoter methylation. But in the small number of patients that were in the trial aged between 65 and 70, there wasn't statistical significance seen in that group. And so there had been a question as to whether this type of treatment was suitable for older patients or whether the side effects and the toxicity of treatment might be too great. There have been some smaller studies that have looked in very heavily pre-selected patients, so very, very fit patients aged over 70 who've had what we call the STUP regime and have done well. And so it, again, reiterated that idea that 70 itself shouldn't be used as a cutoff, that it's flexible depending on how fit patients are. So then people have looked at other types of treatments. So rather than the STUP regime, but focusing particularly on the older age group, what is the right treatment within this group? And we know that without any treatment, unfortunately, survival is in the region of normally around 3 to 6 months. And so there's obviously been a lot of work looking at how we can improve that. Radiotherapy alone has been used. The amount of radiotherapy has varied in between different trials, but there are a number of trials that have shown that what we call hypofractionated or shorter course radiotherapy improves survival from this disease and also doesn't seem to decrease quality of life. because that's the focus, is that what you don't want to do is give a treatment that may improve survival a small amount, but actually that time that's left, patients feel incredibly unwell in and cannot have the benefit of being at home with their family, and instead are unwell and in hospital. The usual regimes in the UK are 3 weeks of treatment, so 40 gray given over 15 doses, or six doses, normally given over 2 weeks. And there was a trial that showed in older patients that actually that 6 weeks of radiotherapy alone was relatively similar to 3 weeks of treatment in terms of overall survival benefit. The other type of treatment that's been investigated is chemotherapy alone. So the type of chemotherapy, temozolomide, tends to be relatively well tolerated compared to other more intensive chemotherapy regimes. And so people thought that whether actually if you gave chemotherapy alone versus radiotherapy, whether that would give a similar survival benefit without the toxicity and the side effects that are associated with radiotherapy to the brain. So there were a couple of studies that came out a few years ago, and that looked at comparing temozolomide chemotherapy alone versus radiotherapy alone with slightly different schedules, and actually showed that in patients with MGMT methylation status, that actually you could give temozolomide alone if the other option was 6 weeks of treatment, that actually temozolomide alone was better tolerated and had improved survival. Realistically, in practice, and partly this is due to the next trial that I'll talk about, in practice, I think chemotherapy alone tends to be used more for patients where there is concern that the amount of disease that would need radiation is very large. So when we give radiotherapy, we inevitably have to treat a certain amount of normal brain as well as the tumour. And if that can be contained as much as possible to one section of the brain, then that's fine. But sometimes with glioblastoma, patients get what we call multifocal disease, which is where you get spots of the disease that's visible on a scan spread in different areas of the brain. And we can't give high-dose radiotherapy to all of those different areas. Otherwise, we would give too much radiotherapy overall. And so in those patients, temozolomide chemotherapy alone can be very, very helpful. So more recently, a doctor called James Perry in Canada thought that actually, if we know that in older patients that 3 weeks of radiotherapy is similar in terms of survival to 6 weeks of radiotherapy, then actually what would happen if you did that similar regime with temozolomide chemotherapy given at the same time and afterwards within that 3-week cohort. And so he did a trial that looked at the 3 weeks of radiotherapy with or without the adjuvant and concomitant temozolomide. And it was focused just at those patients aged over 65. So it was particularly focused at patients who would not have been part of the STUP regime. And that showed that overall survival was obviously improved from no treatment, and that it was improved again with giving the adjuvant temozolomide. It also showed, so they did quite detailed work looking at quality of life assessments, and it showed there wasn't an impairment in quality of life from giving the additional chemotherapy. So having kind of summarized the treatment options, there are quite a few, and I found in a paper there's this algorithm that someone has put together that basically looked at these are the options that can be available for an older patient who's had an operation and is then thinking about treatment. Within this, I would also say that there's a number of patients who were, if they're very, very fit and over the age of 65 patients, people would still give the STUP regime to as well. So that can be added into this algorithm. But I think the bit that most interests me is this first section where the lines divide into what we call KPS over 70 or under 70. And that stands for something called Karnofsky performance status. And Karnofsky performance status is a way of measuring how active or how robust patients are. And that can then be helpful in terms of trying to assess their risk of side effects from treatment. So most oncologists would want to treat as much as we can, but so long as we feel that we're not doing harm with that treatment and that the benefit of the treatment outweighs the harm. And so judging that can be quite tricky. And so what we have historically used is a type of performance status. So there is another one called the ECOG performance status, which is even more basic than the Karnofsky performance status and just goes from 0 to 5. And the Karnofsky performance status is slightly more detailed, but as you can see here, is still relatively, it's a one-line summary that is assessed relatively quickly in clinic. And so what I've always been interested in is about how we can get a better assessment technique so that even when we have these treatment options, to make sure that the right patient is being treated in the right way. And across a lot of other oncological subtypes of cancer, so particularly in hematology cancers, so lymphoma and leukemia, as well as in ovarian and some other gynecological cancers, there was a growing interest in something called a comprehensive geriatric assessment. Now, I use the word geriatric with caution, and I don't mean to cause offence because I know it can be a bit of a triggering word, and I don't think that, as I've said, I think age is a biological process, and I think that it's something that we should be better at talking about and assessing. And so I apologise in advance if the geriatric term causes upset, but it is unfortunately the term that has been adopted within the community for these types of assessments. And what a comprehensive geriatric assessment involves is it basically involves a much more multidisciplinary approach. So you would have a dietitian assessing the patient's nutritional status. You would have a pharmacist assessing whether they're on the right medications or whether some of those medications could be reduced, a physiotherapist and an occupational therapist, and often a geriatrician as well, doing a comprehensive review of the patient. And when this has been done in dedicated clinics, quite a lot of the time in Europe, it's been shown that actually a comprehensive geriatric assessment can predict for how well patients are going to tolerate chemotherapy and radiotherapy, and actually predict for overall survival independently of any treatment that's given. And so there's a number of larger oncological groups that have recommended that a screening version, so a shorter version of a comprehensive geriatric assessment, should be carried out on all oncology patients aged over 70. Within neuro oncology, particularly, there hadn't been any dedicated work. And my feeling was that within the neuro oncology community, the deficits that are produced by the location of the tumor actually are really important. So the kind of processing speed or the seizures or the mobility that is affected by where the tumor isn't necessarily captured in generalized comprehensive geriatric assessment techniques that are more to do with physical frailty below the neck. And so what I was interested in doing in my research was looking at how we could improve the neurologically focused geriatric assessment techniques. There were some retrospective studies that have been done looking back at patients and trying to see whether the number of medications they were on before they had treatment or the number of comorbidities they had before they had treatment could predict for outcomes, of which there were some signals that they could do. But again, retrospective studies can be quite limited. And so initially, when I took some time out of my training to do this research, I wanted to know what was going on in the UK at that time. Now, this was back in 2016. And what I did is I surveyed all of the consultant neuro-oncologists in the UK just to see what they had available to them in clinic and what they were doing. Now, comprehensive geriatric assessments hadn't come in at this stage. So unsurprisingly, they weren't being performed. Only about 20% were doing a routine cognitive screening test. So that's just a kind of 20-point questionnaire that's often done in clinic. And in most people, in terms of, I asked them to sort of think about what factors they took into account when they were thinking about treatment decisions with the patient. And obviously a lot of this was about what the patient wanted, but in terms of what they thought might be appropriate for the patient, performance status was the top clinical factor. So I then looked at a study that I did across 3 UK centres, which was basically trying to work out whether within the confines of the NHS, because unfortunately time is pressured and resources are pressured, whether it would be possible to do a neuro-oncologically focused comprehensive geriatric assessment screening within the neuro-oncology clinic. So I included a number of different screening tests. So an anxiety and depression scale, the MOCA, which is a cognitive screening test, and an extra trail-making test B, which is this picture that you can see on the right-hand side. Also looking at activities of daily living, and something called the G8, which is a validated screening tool that has been used across Europe that can help flag domains of a geriatric assessment that might need more work. And this was primarily run by the clinical nurse specialist team. And it was done as a feasibility study just to see whether it was possible within the confines of a clinic to do this. And it was very successful. So we recruited the 50 patients that we needed just within a year. It was a mixed group of patients. So it was patients, and although I've said I don't like using age as a cutoff, unfortunately, in order to design the trial, we had to use age as a cutoff. And so this was done in patients over the age of 70. With, as expected, overall survival, and a mixture of treatments. So some patients with radiotherapy, some just with chemotherapy, and some with a mixture. All centres achieved the recruitment rates that we wanted and managed to complete the assessments that we wanted. But what was more important, I found afterwards, was that the clinical nurse specialist feedback on this was really interesting. So they felt that doing these assessments actually helped highlight some areas of the patient's everyday lifestyles that they might have been struggling with, that led to changes in the treatment plans. And it worked both ways. So some patients who had appeared slightly frailer when they came in, actually having done the assessments, were fitter than were originally thought, and their treatment was a bit more aggressive. And it worked the other way as well. And although the study was not powered to look at particular analysis, we just did some exploratory statistics, and that showed that actually a baseline impairment in people's cognition and processing and memory was a significant factor in their survival. So no matter what they were treated with, actually a baseline impairment in their processing speed had a big impact. And so this was part of the work that I've done, basically looking at how we can improve having a more detailed assessment of patients within the confines of an NHS clinic. But what I also wanted to see is whether we could use any of the information that we already have for patients in a better way. So most patients who, all patients who are diagnosed with a glioblastoma should have an MRI scan as routine, just as part of their diagnostic workup. And most patients, although I've said that some patients obviously have no treatment and some patients have chemotherapy treatment, a lot of patients have some form of radiotherapy treatment. And we know that radiotherapy can include significant side effects, and they tend to affect different people quite differently. So you can get fatigue, headache, nausea, seizures. That's all in the shorter term. And in the longer term, there's evidence of cognitive changes and an increased risk of strokes. But looking across cancer research, it was very difficult to find any information about how you could predict on an individual level who might be more susceptible to these side effects. And my impression is that within this older cohort of glioblastoma patients, or potentially not even older, but frailer patients who you are considering radiotherapy for and talking to them about whether they would like to have radiotherapy, it was very difficult to say who would get a benefit from radiotherapy in terms of improving their quality of life and living longer, as traditionally the trials have shown us, or who may get quite unpleasant side effects from radiotherapy, end up very tired, bedbound, needing high doses of steroids, and their quality of life actually being very poor for their remaining lifetime, which is what we often see in clinical practice. And so what I was interested in, I worked with a fantastic neuroradiologist in Liverpool, is how we could use whether there was anything on patients' MRI scans to look at their normal brain, so not necessarily at the tumour, but at the rest of their brain, to see if there was any factors that could predict whether these patients might be more or less likely to experience the side effects from radiotherapy. And the theory is that if your normal brain was a bit vulnerable, that you would be more susceptible to the side effects from radiotherapy. And so we did a prospective study, so recruiting patients in real time across 12 centres in the UK. And we recruited 126 patients who were newly diagnosed with glioblastoma, aged over 65, who were planned for some form of cranial radiotherapy. And that could be 3 weeks, 6 weeks, 2 weeks, with or without chemotherapy, but they had to be having some form of radiotherapy. And we looked at their baseline MRI scans, and then we assessed via a quality of life questionnaire how their quality of life was at baseline, and then at 4 weeks and 8 weeks after the end of their treatment. And what we hypothesized was that whether there were any markers on their baseline MRI scans that would help predict those patients whose quality of life might be poorer after radiotherapy compared to those whose quality of life was the same or better. And some of this work had come from work that's been done using imaging in dementia research. And so some of the 5 markers we were looking at were to do with damage from high blood pressure or damage from very tiny strokes. And some of it was to do with how atrophied the brain is. So that means that atrophy kind of means the brain is a bit shrunken down. And atrophy can occur from radiotherapy. So longer term studies of patients who've had radiotherapy show that that bit of the brain can become atrophied. So our theory was if there was already atrophy within the brain, then potentially that might mean that you'd be more susceptible to side effects. So the study ran over a couple of years. We opened just before the COVID-19 pandemic, which had quite a significant impact on a lot of clinical trials that were running at that time. Some of our staff were redeployed to other clinical needs. And a lot of our patient follow-ups would change to remote follow-ups rather than face-to-face, which meant that unfortunately we didn't get as many questionnaires back as we would have liked. But we still managed to recruit the number of patients we did, which was good. So the mean age of the patients was 72, and actually a lot of these patients received relatively significant treatment. So the majority of them had had good debulking surgery. 80% of them received radiotherapy and chemotherapy. Kind of half were 6 weeks, half were 3 weeks. And so these were patients who had obviously come into clinic and had discussed with their oncologist and felt that they wanted the maximum treatment, and their oncologist felt they were fit enough for the maximum treatment. But looking at the scans for patients, we looked at the 5 different markers I've talked about. And the really strong one that came out was about what we call global cortical atrophy. So that's to do with shrinkage of the whole brain. And that was significantly related to a change in quality of life score at 8 weeks after treatment. So basically patients, and it was a linear relationship. So there weren't particular cutoffs that said, if you have this degree of cortical atrophy, you have this degree of change in quality of life. But it was a continuous scale. So patients who had a greater degree of atrophy, we found that they had a strong relationship with a corresponding decrease in their quality of life 8 weeks after radiotherapy. And that continued actually through to overall survival as well. So this was irrespective of the treatment received, and actually also irrespective of the size of the area treated. So that was one of the things that we were interested in, was that if you had patients who had a very big tumor that had been taken out, but therefore you were treating a much larger bit of the brain, the assumption was that that would mean that the side effects would be worse. But actually we looked at that data. So we from all of the centers sent us what we call the planning target volume, which is the volume that receives the high dose of radiotherapy. And actually that wasn't significantly associated with change in quality of life or with overall survival, but the degree of atrophy was. So it showed that patients who had above the normal level of atrophy were less likely to survive, and were also less likely to even attend the 8-week follow-up visit. Now, as I've said, our data was affected by the pandemic, and so this is exploratory analysis rather than definite statistics, but it's very strong exploratory analysis. I think also what's interesting is that so although a lot of these patients were obviously fit enough to have this treatment, quite a few of them, so 35 out of the 126, were too unwell to complete the questionnaires or had passed away by the time of the 8-week follow-up visit. And we know they didn't not attend because of COVID. We knew they weren't. We collected that data, and actually these patients had unfortunately deteriorated to the point where they couldn't come to hospital. And I think that says potentially quite a bit about the treatment that we're offering in terms of assessing patients better to see that obviously we should offer the most aggressive treatments to those patients who will get a benefit from it. Potentially, if some of these patients had had 6 weeks of treatment and then even just 8 weeks later had died or were too unwell, then that was 6 weeks of daily hospital visits that potentially wasn't the most suitable treatment. So just to sort of summarize the BRITER study, the important thing I found was to try and use images that were, or use data that was readily available. So the NHS is under huge resource strains, and I thought doing a study which involves very fancy imaging was a bit useless because no one's going to be able to do that in their day-to-day practice. And so the BRITER study used just routine baseline imaging, but it showed that that can help predict the individual risk of radiotherapy-related toxicity. And so in looking at the scans for patients, so often when people come through the MDTs, the multidisciplinary team meeting that occurs weekly in most centres, where new patients are discussed with the radiologists and the surgeons and the oncologists and the allied health professionals, that you could ask your neuroradiologist how much atrophy is there, and that could then help guide either how aggressive or less aggressive you were in terms of your dosing of radiotherapy, and how you then spoke to people in clinic, spoke to the patient in clinic about how to roughly try and gauge what they might expect from treatment. And obviously the treatment patients choose is very much their decision. But if you can give people a better idea of what to expect from that treatment in terms of side effects, I think that can only add to the richness of that decision making. So looking forwards from here and kind of carrying on the work, I think partly what I'm interested in now is trying to put these aspects together. So looking at MGMT status to help influence whether we think about chemotherapy or not, looking at the degree of brain atrophy to talk about the degree of radiotherapy, but also working really closely within the multidisciplinary setting to improve that geriatric assessment technique and then take that further. So across other tumour sites, they've looked at what they call prehabilitation. So patients where they've had a geriatric assessment performed, certain deficits have been identified, and then an intensive program of physiotherapy or speech and language therapy or occupational therapy or dietitian review or polypharmacy review has been instigated in order to try and reverse some of that before treatment starts. Now, in high-grade glioma work, I think that is tricky because of the pace of disease and because this is an aggressive condition, you don't have a huge amount of time and you wouldn't necessarily want to delay the onset of treatment for that. But I think it's really important to try and work with our allied health professional colleagues to try and see if you can integrate that service much better. And I think different centres across the UK have incredibly different models as to how much access they have to allied health professionals, who is around within the clinic, how easily they can access services, whether they work in a standalone cancer centre or whether they work in a generalised hospital where you have more access to geriatricians. And I think having some slightly more unified process to ensure that patients' fitness is optimised as much as possible to help them through whichever treatment they decide would be something that would be really important going forwards. And similarly to a physical rehabilitation schedule, whether there might be any evidence behind doing a cognitive rehabilitation schedule in terms of improving cognitive performance to see if that can then help improve outcomes. Thank you very much for your time.